So if I could just introduce myself, my name's Adrian Williams. I'm sharing a session which I think is relevant to what I've been doing for the last few years. I worked for NHS England for some time until last year when Niran has taken over as NCD for neurology that you should make contact with. I now work for the department on the acquired brain injury bill, which I think will turn out to be relevant to quite a bit of neurology and definitely incorporates more social care than we were dealing with within NHS England. So it's quite sort of refreshing and very interesting, at least from my point of view. When we were in NHS England, we developed some pathways, and the relevant one for today was on movement disorders that has gone out, I think yesterday. There could be more in that on PSP, but it's not too late. The appendices have often got disease-specific slides in them, and I'd be very interested if somebody within PSPA would like to produce one, and we'll add it to, you know, Huntington slides and MSA slide and stuff. So, so I think it would be in your interest to not get forgotten, because those pathways will go out without much mention of PSP at the moment, but it's not too late to change it. So Rachel, I don't know, is going to talk. I'm old enough that I was in at the beginning. I was for a while patron of the MNDA, medical patron of MNDA, going back a very long time, and was there for the decisions and the beginnings of the MNDA centres, and I'm very pleased how successful they've been. So if I could hand over to Rachel to give her talk.
Thank you. Thank you, Adrian, for your introduction, and thank you for asking me to talk today. Can you hear me okay? Can you hear me? Good.
Yes, yes,
okay,
I can.
so
Sorry, yes.
I'm just going to share my screen. If I may, sorry. Can you see these slides?
Yes.
Okay, lovely. Well, yes, I'd like to thank you for inviting me to talk. And I've been asked to talk about the M&D care centres, really, and to share some of the things that we've been doing. As Adrian says, I think things have grown over the years, and I hope to be able to share some information. Look, very much I've been listening today, and again, finding what's happening in PSP, you know, really fascinating. But as you were mentioning, and it started really, the care centres from the M&D Association had an idea. It was in 1990 really to start to develop care centres across the country, and these were based in regional neuroscience centres, and they were to dedicate the care for one kind of expertise in motor neuron disease, to have a single point of contact with multidisciplinary teams to be able to manage the care of people living with motor neuron disease. And at that point, care was very fragmented. Various neurologists were seeing maybe one person with MND, and in some occasions were saying, well, there's nothing I can do about it, go and live your life. And actually being able to go for that person living with MND to one place who specializes, who understood and could dedicate their time and thoughts to MND was quite a unique thing at that time. And over the years, these care centres, one of the first ones was set up in King's, I believe it was in King's in London, and they developed over the years, and I think Oxford, the one that I worked in, came in kind of 10 years after the very first one. And there's now a network of 23 care centres across the country. Not all of them are actual care centres. Some of them are literally networks, like down in Cornwall. There's a kind of a network because of the the environment and the distances travelled. So there's various points, but not just one dedicated care centre. And the idea was to have these care centres at a place where patients actually didn't have to travel more than an hour or so to access any of the care centres. And it was a place where kind of research and the voluntary sector and health services could all work together. And in Oxford, we now see people from this whole area, really. There are care centres in Bristol, and yet we do have patients travelling from as far as Taunton and down from Bournemouth. But the red area is really our catchment area, and where we see people living with MND. There are 5,000 people in the country with MND. Living at any one time, and we probably see about 300 or 400 of them. And as I mentioned, it's just about the patients being able to have rapid access to therapies, where we can look, and they can, as you've talked a lot about clinical trials today and research, really is a place where we can develop. It's not only the care, but the research can run hand in hand, because patients giving their time is incredibly generous. And if they can coincide with their kind of clinical visits, it kind of makes things more kind of accessible for the patients, really. And as things have grown over the years, I've been the care centre coordinator for 20 years now, and things have grown tremendously. And we have a very large research department, as well as clinical psychology, occupational therapy, and kind of the whole range of multidisciplinary team. We don't have a building as such, it's a virtual clinic, but we all come together on a Monday and see the patients. We see people, so we have a newly diagnosed clinic on a Monday afternoon where we normally see about 4 people. And during that time, they will see one of the professors, or possibly 45 minutes to an hour, and then I see them after. Following that, they can come to a nurse-led clinic within 2 weeks to 4 weeks, just to catch up and see if there are any questions. But then they start to come to clinic 3 monthly from then on, where we can kind of think slightly more proactively about their care. They're very interested to discuss research and clinical trials. And so that's been very helpful. And with the MNDA and the care centres, we lobbied, and I think there's a talk next on NICE, we lobbied the NICE guidelines to make our own NICE guideline, which has had a big impact on care, I think, and the quality and the standards of care. And putting that down in a guideline has been really helpful. During the clinic visits, we look at various aspects of patients that they may be struggling with their nutrition, and we know how important nutrition is to maintain a good weight, can basically really help with their power and how they feel and their energy levels. And we have to think about how we can continue to maintain their nutrition, maybe thinking of timely pegs or rigs. And we have a kind of developed a traffic light scale in order for us to enable us to do these maybe at a time when it's slightly more challenging. So we're always looking and reviewing nutrition. We're thinking about emotional support too. We have a clinical psychologist who talks about adapting and coping. Sometimes, occasionally, within motor neuron disease, there can be cognitive changes, which are kind of challenging for the patient and the relatives to deal with. We look at, although we're not experts, benefits and grants, and we're very much talking about planning an end of life and living well with MND. We're also thinking about enablement, and respiratory care comes hand in hand with that, and monitoring their respiratory output and function. And we work very closely with the sleep and ventilation team to enable people to sleep well, really, and maybe using the non-invasive ventilation. The one big issue is very often head support, and we look at collars and posture, mobile arm supports, wheelchairs, bed comforts. So we can, our occupational therapist is very much involved with that, and she might do home visits and work with the community team too. And that's kind of, in a nutshell, the care centre and how they work. The ones across the country, as I say, there are There are 23, and I think we all work very slightly differently, but we can outreach, and we communicate with them and meet regularly and learn from one another too. That's it in a nutshell. Thank you.
Rachel, thanks ever so much. It's lovely how things have developed, and I think a lot of other conditions would follow an MND on us, and it's amazing. It's actually been going on for how long? 30 years.
It has, and it's funny because I was wondering at some point somebody thought about it, and clearly it was you. So we have a lot to thank you for.
No, the then chief executive, and I can't remember everybody's name anymore, but I definitely went along with it, but they came up with the idea and pushed it really hard. And as you can imagine, the funding in those days and the funding of the first nurses was not an easy road. So it was quite tough at the beginning, but it was the MNDA that really pushed this.
Yes, yeah.
So we'll take questions later. Boyd, I know you were introduced in your earlier talk, so do you want to take over, please?
Thank you very much, and thank you, Adrian. I may be talking to you after this talk. I have just talked, and so hopefully everybody remembers that I'm a consultant neurologist working in Wessex or around Southampton. And my title of my talk was NICE Guidelines and Making the Case for Those. The problem. So I'm talking to everybody who knows PSP and CBD intimately. And so I probably don't need to tell you, but for others, I would usually show this slide. And this is a slide showing the quality of life for patients with PSP compared to other members of society. So the general population, you see that big black square on the top, that is where the general population sit. That's good over this side. Motor neuron disease is here, so less than half what the general population show. PSP is the big red line here, and that is the worst quality of life out of the ones shown. And in order to try and improve people's quality of life with the disease and help them as much as possible, you need a lot of people. And these are all the people that were established from a PSP Association care pathway probably about 10 years ago now, which I and others on the call helped with, talk about things like a specialist nurse or a multidisciplinary team. And I thought I'd share with you some illustrative audit results that we carried out a few years ago. So one of the registrars in our centre carried out freedom of information request to all the trusts, all the NHS trusts in the country, and asked them if they saw people with PSP and CBD, and if so, what kind of setting they saw them in. The red dots here are specialist centres that see only atypical Parkinsonian syndromes or PSP and CBD. The green, I think, are movement disorders clinics. The yellow are movement disorder clinics, of which there are quite a lot, and the green are just general neurology and geriatrician clinics. And of the 127 trusts contacted, only 75 gave information, 21 of which were general neurology or geriatric clinics, 36 were movement disorder clinics, and 8 were specialist clinics. One of the biases might have been that looking at the data, it looks as if most of the specialist clinics were on the audit, but we don't know how many general clinics there were, and it could well be that it's much easier to get the information that we were requesting if you've got a specialist clinic than if you've got a general clinic. And so we may have not reached all the general clinics. So the audit results showed that of people who had access to a therapy or specialist nurse sitting in the clinic, 88% of people who came to 88% of the specialist APS clinics had someone sitting in clinic with them, and only 10% in the general neurology clinics. And the total percentage of patients with regular access to MDT members, so that's multidisciplinary members, so people like physiotherapists and speech and language therapists and occupational therapists who are so useful, was 88% in a specialist clinic, but only 21% in a general neurology clinic. So we had said in the care pathway from the PSP Association that you should have access to MDT, you should have access to a specialist service, but actually a significant number of people weren't having access to either. So, so out of the people who had that we contacted, how many people had access to a key worker or a point of contact? And not surprisingly, in the specialist APS clinics and the movement disorder clinics, they did quite well, 86% or 100%, but only 62% in a neurology clinic. We don't know what that point of contact was, and it may be that the clinics put down the consultant secretary, and as I'm sure you'll be aware, it's quite hard to get hold of consultants sometimes. And in terms of follow-up, they were largely just keeping to the same regime of seeing people every 6 months or so. So how do we encourage the NHS to set up more specialist clinics? So one way we could do that is by thinking about NICE guidance, as was mentioned previously. So in terms of NICE, NICE is a government-backed institution, if you like, whose role is to provide guidance to the NHS. And they say that they use the best available evidence to develop recommendations to improve health and social care. And importantly, you can see this area highlighted in red. Once NICE have published some guidance, the NHS say that you have the right to drugs and treatments that have been recommended by NICE for use in the NHS, if your doctor says they're clinically appropriate for you. And you have the right to expect local decisions on funding of other drugs and treatments to be made rationally following a proper consideration of the evidence. So they carry quite a lot of weight, quite a lot of statutory weight that people have to pay attention to. So as was previously mentioned, NICE did publish some guidance about motor neuron disease, in particular assessment and management, and the guideline covers assessing and managing motor neuron disease, and it aims to improve care from the time of diagnosis and covers information and support, organisation of care, managing symptoms and preparing for end-of-life care. So the whole journey of the patient all the way through their disease, from the beginning to the end. So they recommend an MDT clinic. They recommend the aspects of the disease that should be monitored. They recommend which professionals should be in the MDT. They also recommend who the team should have collaboration with and lots more. So the fact that NICE published guidance on MND meant that I got an email, this is my email, that I got sent by the medical director of Salisbury Hospital, because I'm a visiting neurologist in Salisbury Hospital, asking me, can you please look at the NICE guidelines that have just been published? This is a regular occurrence. Every new guideline gets someone to have a look at it and see what they're doing. Can you audit our practice against the NICE guidelines? And if it's, can you work out how we should alter our practices to fit in with the NICE guidelines? So that was very useful for me because I set up the motor neuron disease MDT in Salisbury. So we have a virtual clinic every 2 months where we talk about everybody with motor neuron disease, with therapists, speech language therapists, dietitians, palliative care physicians, and everybody else. Because it's me, I've also snuck in my patients with atypical Parkinsonian syndrome diseases such as PSP and CBD, so that we also get a bit of an MDT for those patients as well that are around Salisbury. So it seems like quite a good idea to get some NICE guidance published on your disease. So how would you go about getting that? So NHS England can request NICE to review a disease area with encouragement, and we heard that the MNDA previously had encouraged people to encourage the NHS to request for a NICE review of motor neuron disease treatment. The recommendations, though, need evidence to prove that one course of action is better than another. So it's no good just saying, no, we think this is a really good idea, you should encourage it. You need to have some evidence, some studies to show that it is a good idea. And then NICE convene a group to look at all the evidence and make recommendations. And ideally, you need more than one study to prove that a course of action is worthwhile. They're not going to just take one study. So the PSP Association funded me to carry out one of the possible studies. This is a pragmatic study based just within my service, where there is variations within the service in terms of the therapists that are available and the services that are available within Hampshire, Dorset and Wiltshire. And so we look at people's quality of life and how much people use health services. And we look at the variation in our region to see if we can spot if that variation leads to worse quality of life or more use of health services. And so hopefully this will give us at least some pilot data, but perhaps even some useful data to say that actually these services are really helpful for our patients to enable them to stay at home and have a better quality of life. So far, we've recruited 30 or so patients. So it's been running for around 8 months or so. It's going to be running for 2 years. More people are going to be recruited, and we hope to give more answers in the next couple of years. But more and better research is needed. To give you an idea of how difficult this is, I have approached a number of big funding organisations to try and get this evidence to prove what we should be doing, but that wasn't funded. So is there another course of action? So we could collate evidence. So we could do the studies and collate the evidence to enable a keen clinician, and clinicians are always coming from other clinics to come see our clinic to see how we set it up, to get those keen clinicians some evidence that they could talk to their managers about how to set up a clinic in their region. That's quite time consuming. For Adrian's benefit, I'm about 20 seconds away from finishing. We could get an official care pathway, such as the optimal clinical pathways, and I think this is what Adrian was talking about earlier, which might be helpful to establish some information for the NHS to use, but I don't think it's mandatory for them to use. We could get a service specification, which is where the NHS say this is what we expect people to provide in the local areas, and that largely goes to the integrated care boards who decide care in the local areas. But again, that would be something that Adrian would know more about. Or we could get a treatment developed, as others have talked about, which would need patients to be seen in a specialist centre, and then everyone would have to be seen in a specialist centre. So thank you very much for listening, and I'm happy to take questions.
Thanks a lot, Boyd. So your questions were really to me, I sort of slightly covered really. I think if you or anybody else from the PSP wants to liaise with me, we can definitely get an appendix into the movement disorder fairly quickly. And I don't think it would be a lot of work. I mean, I think we did try previously, but something went skew with. So, but it's not too late. So we can definitely do that. I think working with NICE, I take my hat off to you. It's, you know, it's hard work, but it's the, you know, the right thing to try. I think once we got the appendix in, it'll become part of the transformation project, and Niran, you're absolutely right, has taken over from me within NHS England, and we could talk to him about it. But I think the first step would be, you know, to get something on paper, really. I mean, we're dealing with a complicated bureaucracy, and some things that may be obvious to you need to be written down for commissioners, or things will just, you know, fall off the edge. So we could talk about that later. So so there are some questions. So the one I saw a minute ago was about compassionate use of drugs, investigational drugs for patients who are not suitable for you know, whatever trials are running at the moment. So I guess that's a question for you.
So compassionate use of drugs, I think that has been a feature in some other diseases previously. I think, as James was alluding to previously, if there is a drug that is licensed for another condition that you want to use for PSP, and you can make a strong case for that, then usually both commissioners, trusts, and other doctors would be happy to support that decision. Clearly, the onus for that decision to prescribe it is on the person who's prescribing it. But for example, we have prescribed atomoxetine for a similar condition, multiple system atrophy, for a particular indication, which is completely unlicensed, but for which there is research. And that was accepted by various bodies that we had to pass it through. For the compassionate use of medication that's in trial, that's very difficult. And in some way, in the past, the use of medication compassionately while a drug is still being trialed has has disrupted the proper trial outcomes, with people going out and seeking the trial drug when they're supposed to be on the placebo, and therefore disrupting any evidence that would be sought by the drug company to know actually if it worked or not. So compassionate use of trial medication would be very difficult, I think.
Okay, there are some other questions, some of which have been answered already in the chat. I think I know what you're going to say about, are you getting enough funding from government? What else can we do for swallowing in PSP? Perhaps you could answer that one.
So are we getting enough funding for government? I think somebody, I was looking at the chat when you asked me the last question, and I got, I haven't been able to look at the chat properly, but essentially someone had mentioned that people don't know about PSP and CBD, and they know about Parkinson's disease, and they also know about motor neuron disease. And so a lot of the services and the therapists in the community will say, oh, you've got motor neuron disease, you must get treatment with really quickly. So a wheelchair will arrive within probably about 8 weeks for someone with motor neuron disease, but it may take a year for someone with PSP or CBD. And that's part of that difficulty of not knowing about the disease. Equally, funders from government and MRC and other bodies don't really know about PSP and CBD, don't really see the benefit of research in it when there are so much other things to spend money on. And so that's the first question. I agree. I don't think we get enough money. What was the second question?
Swallowing.
Swallowing. Is there treatment for swallowing?
Is there more we could be doing?
So I think most of the all of the specialist centres, and I'm sure most of the movement disorder centres will have in their minds that they need to address swallowing early on in the disease. Think about monitoring it, seeing when it is starting to falter, and then thinking about making some decisions with the person with PSP or CBD about what people would like to do about that. And that's think about feeding tubes. There's quite a lot of research that needs to be thought about in terms of whether feeding tubes are useful in the long run for people with PSP and CBD, and how early you should be offering them and giving them. Nutrition, as someone mentioned before, is very useful for diseases generally. There are no treatments that you can use to stop swallowing deteriorating, as far as I'm aware.
Lovely. Well, thanks to the speakers, thanks to the audience. There are a couple of other questions that are quite detailed that I'm sure you'll answer for them in the chat later. But I think it's I think it's all of our tea times now. So thanks a lot, everybody.